Okay. So, good evening, everyone. First of all, I'm really happy to have so many of you join us for this webinar. And before we begin the session, I think we can have a small poll. Ria, yeah, okay. So you guys can send in your answers. Yeah, I think we can close the poll so we can show the results. Okay, so a lot of you got it right. It's celebrated on 21st September. We have two more questions for and we won't be giving this much time. We'll be closing it in around 30 seconds. So yeah, next question. Yeah, I think we can close it. Okay, so I'm actually surprised. A lot of people got this also right. The theme for this year's Alzheimer's Day is Let's Talk About Dementia. And the World Alzheimer's Society is highlighting the importance of talking about dementia. So they want to raise awareness about how it impacts the daily lives of people affected by this condition. Okay, so the last question. Yeah, I think we can close this. Yeah, actually, females have a more higher risk factor for developing Alzheimer's disease compared to males. Yeah, so that's about it. We can end the poll, and now I can begin. Okay, so um, good evening, everyone. My name is Gayatri Menon, and I'm a final year medical student from Yenepoya Medical College, Bangalore. I'm a member of the IAGSC, which stands for the Indian Academy of Geriatrics, the student chapter, and I'm one of the moderators for today's event, along with Isha Nobe. So, the Indian Academy of Geriatrics is another big organization, just like the Indian Academy of Pediatrics. And Prabha Ma'am is a part of the IAG as well. And the student chapter is something which has come up recently by the students themselves. And now we are a national organization with students from all over India. So, first of all, I'm really happy to see that so many of you have joined us. And this event is one of our many efforts to spread awareness about Alzheimer's disease, since this is the World Alzheimer's Month. And I can assure you that the session will leave a deep impact and change the way you look at dementia and Alzheimer's disease. So now I would like to introduce you to Dr. Prabha. Um, so with a teaching experience of more than 30 years, Dr. Prabha Adhikari is a well-renowned doctor and professor. She has completed her MD in General Medicine from KMC Bangalore. Apart from her other degrees, she also holds a PG diploma in Geriatric Medicine, a PG diploma in Clinical Research, and a bachelor's in Public Health. She is currently a professor of internal medicine at Yenepoya Medical College and former HOD in the same department as well. Dr. Prabha is also part of many social initiatives. She has created at least 8 centers for active aging in the city of Bangalore and also set up 7 free diabetes clinics catering to the need of more than 2,000 older diabetic patients. She also runs a comprehensive geriatric clinic at Yenepoya Medical College, Bangalore. And beside this, she is also running a memory clinic and several active aging programs. She has numerous publications in a lot of well-known journals and is also a member of multiple geriatric bodies, of which she is a life member and joint secretary of the Indian Academy of Geriatrics. So without any further delays, I would like to call Dr. Prabha to begin the session. Over to you, ma'am.
Is the screen visible?
Yes, ma'am.
Hello.
Yes, ma'am, your screen is visible. Yes, ma'am.
Okay. Okay. I'm very happy to be with you all because I think, first of all, geriatrics itself is a topic which is not very attractive to many doctors, including young students. And secondly, if we talk about dementia, where we start off saying we don't have cure, that rarely interests young people. However, the title is very, very nice, what you have chosen, that is Demystifying Dementia. And that's a very important one. And I'm going to speak about the theme that you have chosen as well. So, if you talk about dementia in India, this is a state of several demented patients at home. I do a lot of home care and I find quite a few elderly who are chained like that, and people don't know what to do with them, because if you just leave them around, they may run away. And even if you sort of keep them in the house, they may harm themselves. So this is what most of the helpless children do, because they are not aware of it. And some neighbor may think that the elder abuse is happening, and even police may intervene. But if you really know what is dementia, I don't think we need to chain them like this, because we can give them care and they will respond to our care. So if you talk about my experience with dementia, when my parents grew old and they were actively aging, as you can see the picture of my father with my daughter and my mother being very active. So they both of them were very active. My father retired at the age of 58, but until 75 he was engaged in various educational institutions. He was the principal of a college and a professor of physics, and he authored the textbook, PUC textbook of physics, and he used to be very, very busy, either writing or actively aging and participating in all the activities of educational institutions in and around the city of Bangalore. He was active in the university. He was responsible for setting up Bangalore University. He was a member of several social organizations, and including Home for the Aged. He helped a lot, and Association for the Blind, name it. He was very, very active. But after the age of 75, something happened. It so happened that he developed macular degeneration and he has lost vision in one eye, and the second eye also he was losing vision. That's where his mental ability started declining, and his personality was totally changed. he started having confusion, he started miscalculating. Although he did get vision back after some time in one eye, still he made lots of mistakes in calculations. 1002, he would write as 1002 and it would become 10,002, and he would try to add it up. It wouldn't make any sense to him, and then he would get scared that he has lost all his money. He was a very regular income tax payee, and even like for 1 paisa earned, he would pay. And he would get scared, saying that he has not paid his taxes, although he has paid, and he would always think police will come and arrest him. So that was a cause for fear, because he would have just forgotten that he has paid the taxes already. Slowly, he would also disappear, saying that I have to go to the income tax office. And he used to do a lot of our work also. If I had to travel anywhere, if I inform him, he would go and bring the ticket for me. But suddenly I was surprised that he brought the wrong ticket and to the wrong place suddenly. So all this changing behavior continued and continued. It became so severe that he was not able to recognize some familiar people, including my mother, although he was able to recognize me. So this was very puzzling, but it would occur for some time, and then sometime he would be all right. So at that time, it was much before 2000, year 2000, and awareness regarding Alzheimer's disease and dementia was not very much in the city of Bangalore. Although I took him to several neurologists and senior physicians, they would say this is some acute confusional state. So there may be something reversible, and they would search for a reversible cause. Although he would improve with the identified cause, he would still have abnormality. Then when it went to the level where he was not able to recognize my mother, I thought there was really something wrong with him, because what he would do is early morning he would get up. My parents used to live upstairs and I would live downstairs. My father would come down for a walk. He would have had his morning coffee, and then he would come down and go for a walk, come back. And towards evening, he would bring all his fixed deposits, and he only had one gold earring, which he would hand over to me, saying that there is a stranger sitting in his house, and there would be nobody other than my mother. And however much I tried to reassure, he wouldn't get convinced. So he would hand over to me, and I would just agree with him and keep it with me. Next morning, he would come and collect it back, saying that I have given you FDs, so I'll take care of it, give it to me back. So this would continue. So in desperation, as the deterioration continued, and he started also falling, I took him to NIMANS, because I thought that's the ultimate for diagnosis of neurological conditions, where they did some screening tests. I think all of you are aware of MMSE, which is used for memory testing, and very peculiarly, he scored very well in that. He scored as much as 27 out of 30, and the neurologists were puzzled. Here is a person who can't recognize his own wife, but he's scoring very well in MMSE. And the date, orientation, everything was perfect. And even residents got surprised. So then they decided they will admit him and then evaluate him. Then he went through a thorough neuropsychological evaluation, and all lobar functions were assessed. And then they declared that he has multiple lobar involvement, and this is nothing but dementia, which is a mixed dementia, both Alzheimer's and vascular. And at that particular time, other than making the diagnosis and asking us to join a caregiver group to get educated, there was nothing else. And they said whenever he behaves differently or when it's difficult, I can use olanzapine. So I did try that olanzapine, and just one dose, he slept for 2 days and did not take any food, and I decided that's not the right drug for my father, and I opted not to give him any drugs, and then start a center exclusively for him and his friends. That's where I started a daycare center for active aging. where I enrolled him and a few of his retired friends uh, for an active aging program where physiotherapy department said, here we are ready, we are very much interested, so let us have a center. So that's what I started in KMC those days, which we called as KMC Nava Chaitanya, just to rejuvenate our elders. This was the most important intervention which changed the life for my father. He would have a place to go because every day he would get up and say he's the principal of a college and he has to go, and if he doesn't go, the college is going to collapse. He would say today is college day, another day he would say it's exams, I have to be there, and the chief superintendent. And my mother would say you have retired long back, and it would irritate him. So here was a place where he could go every day. So I would take him to the center every day where he would meet his friends and say hello to them, and they would be very nice and they wouldn't worry about his cognitive function. They would treat him as the principal, and that was very, very comforting for him. So he continued to attend this center where he improved a lot. We even conducted some memory, once a week we would conduct some memory classes. Meanwhile, we were called back by Niman saying that a new drug has come, whether we would be interested in trying it. So I was really happy to try anything possible, and Rivastig being the first anticholinergic agent had come to India, and my father was the first one to have received it. With that, my father did show quite a lot of improvement. He started recognizing my mother and all the other people, and although later he did have a fall and intracerebral hemorrhage, because of which his he lost his speech and he was not able to speak, but he was still able to communicate. So he continued to go to this center where it kept me engaged. He was exercising, there would be entertainment, there would be enjoyment, and there would be even educative lectures. And he would also be useful because all the physiotherapy students would love him and give him physiotherapy, and he would be kept for exams, and he would enjoy that. Being a teacher, he was very happy to be a patient or a case for the students' exam. And also he would go to the speech center, or after the fall he had lost his speech, where small kids would come to learn speech. They were hearing impaired children. They would call him grandpa, and sit on his lap, and the teacher they would use him to teach speech to the small kids. Although he never learned to speak again, he had learned the art of communication with the small kids, and he would smile at them and they would say tata, bye bye, etc. So this was the intervention which really was very, very helpful for the entire family and for him also. So this is a simple thing that I created at that time. Although today my father is no more, I see that the center is useful for many elderly, which is keeping them occupied and engaged. So look at the burden of dementia. As per the 2015 statistics, 50 million worldwide dementia patients, and every year 10 million new cases get added, and one new case every 3 seconds. As we are lecturing, I am sure many new dementias would be diagnosed. And in India, we currently have about 4.1 million dementia patients, and earlier we used to think it's a disease of the richer countries. That is because activity was only seen in those countries. But today it is the disease of the developing countries, and more than 2/3 of dementia patients currently are living in developing countries. And it is a very expensive disease because it involves the caregiver, and you need to spend on caregiver a lot. And it's a price that we have to pay for living longer. If you can see in this slide here, as the age advances, the prevalence advances. So you can't escape dementia as you're aging, but it is not a part of normal aging. Everybody thinks that we have to forget if we grow old. It's not that it's compulsory. You can see here at the age of 90, we have around 40% of them having dementia. So, what is this dementia? Dementia is an umbrella term. There are many types of dementia, and Alzheimer's disease is one such dementia. The current term for dementia is major neurocognitive disorder. It's like any other organ failure, it is a brain failure, that's all. Dementia is nothing but a chronic, irreversible brain failure. That is dementia. When it's acute brain failure, we call it as stroke, or we call it as delirium also. Acutely, even in delirium, you may have neurocognitive disorder. So, definition of dementia says that there should be progressive loss of memory for at least 6 months, which interferes with normal living, with one or more other cognitive functions such as thinking, behavior, or language getting affected, which is not explained by depression or delirium. And very often these patients have aphasia, apraxia, and agnosia, and loss of executive function. So then only we call it as dementia. So just simple memory loss, we call it as mild cognitive impairment. But if it is memory loss which interferes with living, which also encompasses other cognitive, which also involves other cognitive functions, then it becomes dementia. So what is Alzheimer's disease? It is a type of dementia which we call as tauopathy, because it's characterized by accumulation of tau protein in neurons and amyloid plaques in between the neurons. So tau protein gets precipitated as neurofibrillary tangles, resulting in cell death, and amyloid plaques will destroy the neuronal connections. So at the end result is devastating chronic brain damage, and it can be only diagnosed by a brain biopsy or a PET or a functional MRI, and CSF protein, you may get tau protein in CSF. So this is the pathology of Alzheimer's disease. You can see the normal neurons here and the connections. So you can see here how amyloid plaques are deposited in between the neurons, and these pink things are neurofibrillary tangles due to precipitation of tau protein. So what are the risk factors? I think just now Gayatri conducted a quiz and she said female gender is more at risk. It's absolutely true. For some reason, female brain is supposed to be smaller, so we have less cognitive reserve, and so the female brain becomes a risk factor. Age is the biggest risk factor. As I said, as age advances, the prevalence increases. Genetic factors are there, but it is accountable for only 10% of Alzheimer's disease and other dementias. We have a lot of modifiable risk factors, and that is interesting for us because if we can't treat dementia and cure dementia, we can prevent dementia. So we have 3 early life risk factors. Poor fetal nutrition, that is resulting in low birth weight, that itself is a risk factor. So if you want to tackle Alzheimer's, we have to look at the maternal nutrition. Low education results in poor cognitive reserve, so brain cells won't increase in number, so we will have a poor cognitive reserve. Psychosocial stress in childhood, that also results in poor cognitive reserve. So these are the 3 childhood risk factors which we can address. We can educate children, we can look at fetal nutrition, and we can also address psychosocial stress the children are going to have in life with early life intervention. Midlife, we have 6 risk factors: hypertension, dyslipidemia, obesity, physical inactivity, hearing loss, and alcohol. So these risk factors in midlife are the most neglected ones. In midlife, we would have reached a very high level in our profession. So we don't care about our hypertension. We will be having a little bit of hearing loss. Again, we will not care about it. We'll have dyslipidemia. We don't exercise. We have obesity. And alcohol becomes a part of life because as you go higher as an executive, taking alcohol becomes a part of life, and even if you're laborer, you will have lots of problems and you want to forget and you're going to drink. So these are 6 risk factors in midlife which we can easily address. Late life, okay, we forgot to do everything right in the midlife. Is there something I can do after I grow old? Definitely. Diabetes, so prevention of diabetes or control of diabetes. Depression, which is very common in old age because you have stopped working and you think nobody cares about you anymore at home because you're not earning anymore. All your friends are gone. You think, oh, that friend died of COVID, this friend died of cancer. When am I going to die? So you are all the time worried. So depression is a very common factor in late life. So you don't have friends, either you are relocated because wherever children are, so you don't have your friends, or your friends are no more and you can't make you hesitate to make new friends. So poor social engagement itself is a risk factor. Physical inactivity becomes a risk factor even in late life, and smoking also becomes a risk factor in late life. So addressing these risk factors, you can really minimize your risk factors and minimize the chance of getting Alzheimer's or other dementias. So there are totally 17 risk factors if you look at from fetal life to old age. So look at my risk factors now. I am 64. I'm female gender. I have a family history. My father had Alzheimer's and vascular dementia. My birth weight was good. I have got good education. I had no psychosocial stress in childhood. I am obese and overweight. I don't have hypertension. I don't take alcohol. I am engaged in physical activity. I have a mild hearing impairment. I have no dyslipidemia. I have very good social engagement because I'm actively working. Plus, I'm connected to senior citizens. I'm physically active. I have no depression. I have no diabetes, no smoking, and maybe I do have some cognitive impairment because I can't remember the names of my students, although I remember Gayatri Menon very well now. I do remember faces. I may forget dates. So Gayatri sent me several reminders, knowing that we are likely to forget. So there are some mild cognitive impairment which I've been having from a very young age. So I do have some risk factors, but I can modify by improving other risk factors and minimize the chances of my getting dementia. If I can't escape dementia, I can postpone dementia. If I were to get it at 60, because I'm actively working, I'm definitely postponing it to 70. And if after 70, I'm keeping myself active, I'll postpone it to 80. And after 80 also, if I'm connected with my friends, today we have good option. You have social media. You can connect to your friends through social digital media. So what are the types of dementia? So dementia is nothing but progressive, irreversible loss of neurons. Alzheimer's disease is the most common type. Vascular dementia is another type, and combined Alzheimer's and vascular is very common. In India, 50% of them are combined. Frontotemporal dementia, a small percentage we have. Body dementia, again a very small percentage we have. Parkinson's with dementia is really increasing. That's with the rise in Parkinson's disease, and rarely we come across Huntington's chorea. I would say out of 100 cases that I have seen, I come across around 3 Huntington's chorea, and these are my figures only, what I have seen in my practice. it's encouraging to know that there are many reversible causes of dementia. They're not actually dementia. If you identify the cause and treat them, they will reverse. So there are metabolic conditions like hypothyroidism, hypo or hyperglycemia, hyponatremia. When it becomes chronic, it may pose as dementia. So if you address it, they will reverse. Similarly, nutritional deficiencies like thiamine, B12 and folate deficiencies can also cause dementia if you don't diagnose it early enough. So we do a screening for these conditions whenever we come across any person with dementia. So very often we may find nothing, but we may get around 5% of hypothyroidism. We may get around 1 or 2% of hyponatremia. We may get 1 or 2% of B12 deficiencies which can address. Bilateral subdural hematoma is a very common cause of dementia in elderly because as age advances, there's brain atrophy. When they, even a trivial trauma or even without a trauma, they can get subdural hematomas. And if it's bilateral, they won't know at all. They will just present with cognitive impairment. So we always do a imaging, and if you find it, we are very happy. The 2-3 cases that I have diagnosed, they bring in other patients because those cases have got cured. They think I am a dementia curer and they think that I can cure them. Similarly, sometimes you may come across a tumor and sometimes you may find a normal pressure hydrocephalus where just putting a shunt can cure them of dementia. Even normal pressure hydrocephalus, among 100 cases, I will find 1 or 2 where I can put a shunt and cure them. Similarly, neuroinfections, delirium can pose as dementia. So you identify the cause of delirium, they will normalize. Depression can pose as dementia. So treating depression will improve dementia. If somebody is an alcoholic, we stop alcohol, their dementia will stop progressing. So these are all reversible factors we search for. And our observation was that as age advances, BP starts declining. So even in my father's case, he was a hypertensive in midlife, and he used to have accelerated hypertension when he was actively working, and he was on 3 medications for control of blood pressure. As he grew older, the blood pressure started coming down on its own because this is because of autonomic dysfunction, and it became pretty low, where I had to withdraw the antihypertensives, which normally we won't do. If we say 130/70, we'll say, let it be. But for somebody with dementia, if the diastolic BP becomes less than 70, they are not going to have brain perfusion because brain perfusion requires a minimum diastolic BP of at least 70. So it's good to increase the blood pressure by withdrawing antihypertensives. But beta blocker is one thing we should never withdraw because it can cause accelerated hypertension. So what is mild cognitive impairment and what is dementia? So as I said, even I forget, and even younger people do forget. Is it dementia? Although in forgetfulness is normal part of aging, quite a few of them may progress to dementia. So it's very important that we keep following them up. So this is just not getting a word, not getting the names of people, not getting dates, but however they're able to function absolutely normally. So differences is, okay, today I was supposed to give a talk and I forgot, but Gayatri reminded me, so I gave my talk. So Gayatri calls me and says, Madam, you had promised to give us a talk today. Did I do that? When did you call me? If I say that, I had dementia because I have forgotten the entire episode of Gayatri calling me and asking me to give a talk. So that is dementia. Whereas if I remember that, yes, Gayatri, you called me, I remember, it is not dementia, it is my cognitive impairment. So day-to-day functioning will be normal in MCI. It is usually only memory is impaired, nothing else is impaired. I can retrieve my memory. Yes, that day you had called me. So and episodes are not forgotten, and loss. I do misplace my things, but my misplaced things are in appropriate place. I keep my glasses somewhere. If I don't find it, but it will be on another table. I keep my pen somewhere, but it will be on another table. Or maybe I would have gone to see a patient. I would have written something. I would have put it on the case sheet. Whereas if I keep my glasses in the refrigerator, if I keep my pen somewhere else where it should not be, then it is dementia. So friends and relatives won't notice the abnormality in MCI, whereas dementia, friends and relatives will notice it. So this is the difference. So mild cognitive impairment and early dementia, you always have a problem. So we need to really investigate such patients to rule out early dementia. So now, when we say dementia, we need to state them, whether it's Alzheimer's or any other disease, because it's important to state them so that interventions can be planned. So you have a big stage of preclinical dementia where nobody knows that you have dementia. Whereas if you do a brain biopsy, you'll find amyloid plaques, you'll find neurofibrillary tangles in cases of Alzheimer's disease, or you may get periventricular ischemia or white matter disease in case of vascular disease. Okay, but patients are absolutely normal. This stage is called as preclinical stage of dementia. Then the stage of mild cognitive impairment, which I described, and then the stage of mild dementia, where maybe instead higher activities of daily living you cannot do. I am functioning as a professor. I may not be able to lecture, but I can live independently. I can cook the routine things, but I cannot cook special items which I used to cook. Okay, so mild dementia, there will be impairment of functioning, but others may notice if they are involved. Moderate dementia, there is dependence on a caregiver for activities of daily living, even simple activities of daily living. I don't know how to take bath, I need help. I don't know how to eat food, I need help. I don't know how to go out of this room. I can't find my way out from this room. Okay, so that's moderate dementia. Whereas severe dementia, I'm totally dependent. I just cannot, even if somebody holds my hand, I can't walk. I'm totally dependent on the caregiver. So that is severe dementia. So we stage them because mild cognitive impairment may be reversible with non-pharmacological interventions. Mild dementia may be arrested with medications, and moderate dementias do respond for cognitive enhancers, and you can give treatment for behavioral and psychological symptoms. Whereas severe dementia, we only do nursing interventions and we don't give them anything else. When I say dementia, it is just, I would say it's erasing of the stored information, skills which are learned, which are lost. So it can be lost layer by layer or patched. So if I talk about a patient with dementia, suppose say I'm 64-year-old. I think I'm 23-year-old. And I think I'm a medical student. So I may be comfortable in the hospital, but I think I'm a student doing MD general medicine. So that is what is dementia. So when I get up, I think I'm an MD student. I have to go to the hospital very early at 7 o'clock and write the case sheet, take the history of the patient, write the case sheet, and then I have to maybe present the case to my seniors. That will be my impression. So whatever, so like that they can go backwards and backwards, and then they may think that they are maybe 5-year-olds and they may fight with small kids. So this is what is dementia. I've had patients where the old lady, she was 18 plus, and she would think she's just engaged to be married, and her son was resembling her husband, and she would think that her son is her husband, and that would irritate the daughter-in-law like anything. And this old lady would think that the daughter-in-law is the other lady trying to hook her fiancé. And she would always hold on to the son and not allow the daughter-in-law to talk to him, and that would cause a lot of distress in the family. So these are the behavioral issues we face. The son was understanding, but the daughter-in-law was finding it very, very hard to understand this relationship. So there are some simple warning signs. So memory loss, interfering with life, unable to perform simple familiar tasks. Like as I said, even taking a bath, they forget. Because it's a very simple task, but they will not know. They will not know how to open the shower. They will not know how to dress. So problems with words or even writing, they will not know how to write. They have apraxia for writing. They know neurological deficit, but they cannot write. They will be looking at the paper, but they can't. They may read the word, but they may not have a meaning to the word. They may have confusion with time and place because their mind says today is say 1956, okay, and they'll get up and think it is 1956, and it may be night and actually, and they may go to sleep. So, or at night they may get up and think it is morning. So they are disoriented with time and place. They may not be able to solve problems, and they cannot understand a visual image. They cannot decipher what that image is. They are blind. They may misplace things and then think that thieves are around who have taken their money and other things. They cannot plan. Their personality changes and mood changes because somebody who is bold may become very, very timid, or somebody who's not bold may become very bold, and they withdraw from their routine hobbies and social activities. So these are all warning signs. Anybody has this, we have to screen them for dementia. So they have lots of behavioral issues. I think Dr. Soumya will be the best person to tackle the behavior. In early dementia, people are aware that they have dementia, so they become very much depressed. In between, they have anxiety because they have fear, they lose things, so they think that there are thieves around, and in later they develop agitation and aggression because they don't understand. They think they are young people and fit people, and people think that they can't take care of themselves, so they try to go and help them, and they get very, very angry, and they abuse, and they may even hit other people and become violent. So troubling behaviors are wandering. Okay, they may wander for two reasons. One reason is they may think that it is a particular time. My father used to think today is college day. I have to get up and go. And in the middle of the night, he would have been missing. He would have walked up to his college, which is government university college, which is still existing, and then he would not find anybody, and then he would come back. In later stage, the wandering is because you lose the way. You don't find the way at all. You will lose orientation to space. So you start off and then keep walking and not come back. So there are instances where a pediatrician was reporting that his mother was wandering and she was found around 36 miles away in a village where dogs had attacked her and really made had many bites out of her, and he knew that he could not take care of her anymore, and then he put her in a care home. So when it's so harmful to them, we have no other option but to put them in a care home. Incontinence, repeated questioning, because you don't remember, you keep on asking the same question. So when are you coming back from the hostel? Okay, you tell, I'm coming back on September 28th. Again, they'll ask, when are you coming back from the hospital? So repeated questions can be irritating. Accusing people, caregiver saying that you have stolen. Loss of language. Yesterday we visited a patient. The patient has completely lost language and just repeats what we say in a different tone. When I ask, how are you? She said, how are you? How are you? And gives a good smile, saying that I'm fine. Okay. I met another patient who was a cycle racist. He would say cycle for everything. So only the tone would change. So language may be lost. They may have hallucinations, delusions, searching for lost things. I had a patient who would go on singing, say same song, same tune, and it could be quite irritating. And the daughter-in-law was smart. She would always sing, having her song book, and she would telephone and sing that song. 24 hours she would sing. So the daughter-in-law tore that particular page, after which she stopped singing that song, and she would probably sing another thing. Somebody who's very meticulous about the house, or they remember how the house was kept, say, few years back, and patient has gone back to those years, he may keep on changing the arrangement of the house. So he may drag furniture. So these are all behavioral issues. Late stages, they just require nursing care. They're bedridden, pressure ulcer has to be prevented. They can't eat, so we may have to feed them, and they don't have speech, so we may have to only communicate with them and show that we love them. So touch, etc., helps in this stage. So although people think they are cabbages, I have seen they do understand love. I remember a patient who was in advanced stage, had no words to say, and she was in a very pathetic stage, and she wanted we arranged for the children to come who were staying abroad, and they came, and the day they left, she wept. So they do have emotions, they do have some kind of life within them. So we cannot think that they are cabbages, because many of the physicians think that they are cabbages. Even from my father, I remember neurosurgeon saying, I will not operate on the subdural hematoma because he is a cabbage. And I was very, very angry when he said that, because I knew my father understood. I knew my father was recognizing me, and I knew my father was capable of loving us, and my father was capable of smiling and laughing and enjoying life. When we clinically examine, we try to examine for secondary causes like Parkinson's. We assess them for lobar functions. We assess them for speech, gait. We look for pyramidal signs to see whether there is a stroke and a vascular dementia. We look for other signs like cerebellar signs, whether dementia is a part of multiple system atrophy, etc. So a detailed neurological examination is a must. In normal pressure hydrocephalus, they have what we call as gait apraxia. They walk with shuffling gait. They have incontinence, and they have frontal lobe signs, and it is a treatable cause of dementia. So we look for treatable conditions and causes of dementia. We do a systemic examination as well. So what are the tests that we do to screen for dementia? In a routine geriatric clinic, I just ask them to remember 3 words and recall it later. The common 3 words that we use are horse, pony, and a coin. And we translate it to local language and ask them to remember. After we ask a set of other geriatric assessment questions, we ask them to recall. So mini cog is the next test that we do, where we have 3-word recall plus a clock drawing test. Many of our patients who are fit also can't draw clock. I've seen even graduates and masters of graduates, they don't know how to draw a clock. So because they're not trained to draw a clock. So if they can't draw a clock, we ask them to read the time in a clock, or we can ask them to draw the house, which we are all trained for. So next test that we do is MMSE, and we can classify dementia based on the cognitive scores also. And there is a Canadian score called as MOCA that we use sometimes, and there's an Australian score which is Adam Group's ACE3 score. So we don't make a diagnosis of dementia by using just one score or one scale. We use multiple things. If by using 2 or 3 we find the same result, and we rule out depression in these patients and delirium, then we call it as dementia. In early dementia, sometimes we may have to do neuropsychiatric battery of tests, which is done by psychologists, and it may take as long as a few days. My father underwent it, and it took around 10 days in a dementia patient, it will take 10 days to do the test, because after 1 or 2 hours of testing, they get irritated and they start scolding, because when they can't get answer to the questions asked, they get really angry. So it will take a very long time. So routinely we don't use it. So this is the abnormality in clock drawing test. You can see the abnormal clocks there. It say that, so if they know how to draw a clock and they draw it abnormally, it could be a sign of dementia, but we don't determine by just a simple clock drawing test. 3-object recall is abnormal, clock drawing is abnormal, and in mini-cog, score is 2 or less, which is a scale of 5. We suspect dementia. This is mini-cog, which is available in the internet, and this is MMSC. Again, it's a paid tool now, but we are still using for clinical practice. But if you want to do research, we can't use this. Then we do a lab test, as I told, rule out metabolic causes. We don't do CSF examination because it's invasive. Again, PET scan, which is expensive, so we don't do. But we can do for research purpose. ApoE epsilon gene polymorphism and resetting genes, we do only for research purpose. So treatment of dementia in early stage, brain stimulation activities and keeping them engaged, physical activity, nutritional diet, and drugs. Okay, so drugs are mainly cognitive enhancers, which include anticholinergics and NMDA receptor antagonists, and psychiatric drugs too, for their insomnia, anxiety, hallucinations, depression, which we may have to use for a short while, and managing comorbidity optimally. So these are the 3 groups of drugs we will use. So exercises in our active aging centers, we have included all kinds of exercises that they will enjoy, including dancing, walking, brain activity, aerobics, yoga, whatever they like, they choose and continue to do. So anticholinergics, as I told, rivastigmine was the first drug that came, but it is expensive. So all of us have now switched over to donepezil, which is cheap, which is improves memory and awareness and the ability to function. We have seen quite a lot of patients stabilizing on this drug. Start with 5 milligram and go up to 20 milligrams. Of course, there are side effects, and you need to watch for the side effects. Again, rivastigmine, as I said, we start with low dose of 3 milligram and go up to 12 milligrams. Those who don't tolerate and develop nausea, vomiting, we use a patch, which we can increase the dose and avoid the GI side effects. Galantamine is another drug. We start with 4 milligrams and go up to 16 milligrams. So one of the drugs we will use in treatment. Next is the NMDA agonist. Memantine is the drug, which is we start with 5 milligram and then step it up. And these are the side effects. So we use a combination of anticholinergics and memantine usually. Newer drugs are in the pipeline. Quite a lot of dementia patients have brain autoantibodies. So using immunosuppression is known to help. It may not be, say, 100% of them. Even if we get 3% of patients who will reverse, it will be a wonderful thing. Especially in pre-senile dementia, we always treat them for autoantibodies. And anti-amyloid monoclonal antibody has just got approved in USA, which has shown very good amyloid clearance with clinical improvement. It has not yet come to India. It will be expensive, but still, the dementia patients who are waiting, who have Alzheimer's or mixed dementias, may get benefit. So while the search for magic drug continues, understanding dementia and its mysterious behavior is going to help a lot. So here is a picture on World Alzheimer's Day, where we have dementia patients and then their caregivers, and we do our walks. Our active aging center today, the center has grown big and around 500 members are there and multiple centers are there. So, and this year we have started online active aging program so that anybody can join this exercise program if they just have a smartphone. And we are educating people, and this time we had to show that family support is important. We had a poster competition, so many caregivers participated by sending their pictures and then slogans. So you can see some of the winning posters here. You can see the family, and there is a very interesting patient whose music and words are intact. She's a great singer. So when we tried to do home visit, we tried music therapy for her. She suddenly started singing, suddenly started playing her musical instrument. She asked for those instruments. She started playing mouth organ. She had a violin, and she was amazing with her words. She would play this fellow-fun, and then in a tab she would make words from any of the letters given. And her grandchildren and her daughter-in-law looked after her very well for about 8 years. Only now her memory is fading more and more, but the memory for music is still there. So whatever they have, we have to encourage them to have. So this is just a poster competition where elders have participated, and this is how it is. You may not know who those other people are because you may not recognize grandchildren because you think you're not even married. So if somebody calls you an old man, you will not believe. So this is again the picture from World Alzheimer's Day. In Bangalore, we have multiple active aging centers participating in World Alzheimer's Day. And here you can see a lady from a home for the aged who's a teacher at 80 plus. And she remembered the dance that she danced when she was in the school. She was a Bharatanatyam dancer, and she danced after nearly 75 years. And that was an amazing dance. And here also, they are dancing that famous song of Radha and Kishan, Radha Kese Ne Jale. It was again an amazing one. So today we have online exercise, and even Bollywood dances our elders are learning to keep themselves active because they can't socialize and all are locked indoors during COVID times. So we are reaching out to them. We are reaching out to our dementia patients either through home care or through telemedicine because we don't want them to come and get COVID here. And we are serving them even during COVID times. So the dementia that my father had gave me something to do for the society. So I always feel that my father is still alive because when I see a dementia patient, I remember my father. When I walk around anywhere, they recognize me as my father's daughter because the good work my father has done is still there as monument. The multiple organizations that he headed and contributed is still there. So they don't die. So this has given me a vision. It has given me some ideal, and it has given me some heart. It has given me some faith. It has given me some hope because I know one day we will win this dementia, and it's given us some melody to sing to and some service which has changed my interest in medicine and moved me to the Department of Geriatrics, and today I'm heading the Department of Geriatrics. I'm not in the Department of Medicine anymore, Gayatri. We are just starting MD Geriatric Medicine so that we produce more and more geriatricians who will give care to these elderly who have made us what we are. So thank you very much for a very patient hearing.
If anyone has any questions, please feel free to unmute yourself and ask ma'am, or leave them in the question panel.
So hello. So I think we should get ready for the next session, and Dr. Soumya Hegde is a very good friend of mine, and I have gone to her several times, met her. We made a documentary together, which I use for my students very often.
Ma'am, there's one question from Saurabh. It's about behavior of forgetfulness at a young age became a risk factor for dementia. Does it happen, ma'am?
Yes, because we call that as mild cognitive impairment. Forgetfulness at a younger age, okay? So it can be a risk factor for dementia. So we need to do everything to get over it.
Okay,
so what we tell the older people the same thing. And have some mechanisms of remembering, etc. Yeah.
Ma'am, one more question from Evan. It says, is it a good idea to keep reminding a person with Alzheimer's about some trauma they forgot, like the death of a loved one?
No, you should not. You should never remind them of painful things, because then they'll be very sad and they'll keep on crying, because they say, like, I never knew about it. I would have done this. I would have done this. So we should never talk about death, because if they believe that the spouse is living, or son is living, or a daughter is living, or a brother is living, a sister is living, it's better that they if they ask about those people, you can just say they have gone out somewhere, they'll come later. I think that's a better idea than go on reminding them painful things.
Okay, ma'am. Thank you.
You cannot see, they are happy in their own world. You should never bring them, try to bring them to the era which they have forgotten.
Yes, ma'am. And one more has come now, ma'am, from Amulya. It says, ma'am, my grandmother is 75 years old and she doesn't have any other symptom except for repeating a few things again and again. So should she be worried?
Yes, definitely, because that means recent memory is getting lost and the person has to be assessed for Alzheimer's, because early treatment really matters a lot. My father got treatment very late, but suppose say I picked it up at early dementia stage. Of course, we didn't have drugs those days. And if you put them on drugs, they don't progress. I've seen patients in the same stage or little improvement with improvement for 10 years. So around 50% of patients treated in early stage do not progress at all.
Okay, ma'am, one more from Saurabh. He says, can you please explain again how antihypertensives can decrease the risk of dementia?
Yeah, because early age, see midlife, if you don't control blood pressure adequately, you will have atherosclerotic changes in the blood vessels of the brain. So, brain as you grow older, because the perfusion is not good, you will have accelerated brain aging, including decrease in amyloid clearance. So, you will have like accelerated dementia. So midlife control is very important. Late life, yes, you will get benefit in controlling hypertension, but midlife control becomes very, very important. But when they grow old and develop dementia, at that time, you try to rigidly control to a blood pressure of 100/60, it's going to be bad. So somebody who has got dementia already, it's better to maintain a blood pressure of 150/80 at least, so that you have a good cerebral perfusion. But if you don't have dementia, an older person also, you control as much as possible. And of course, you have to see his fitness also, because somebody may develop postural hypertension and fall. Those things also you have to consider. So the recent guidelines say for older people, control blood pressure up to 150/80.
Ma'am, does chronic hypertension with MCI put anyone at high risk for Alzheimer's in the future?
Yes, yes.
Okay, and one more by Suyash. Ma'am, what should our approach be in case of elder people with dementia and paranoid ideations? Should we just confirm their ideas and reinforce their beliefs, or directly confront their
I would
poison?
say you confirm the idea and reinforce, and then because you have to live in their scenes, whatever they are saying, you have to believe them. Then they are okay. Otherwise, they think you are also teamed up with those people and scheming up something. That is their imagination. So it's better to go with their ideas.
Okay, thank you so much, ma'am. I'm Isha Nobe, the co-host along with Gayatri, and thank you so much. We enjoyed every minute of it. We were enthralled throughout. We loved your touching personal story and your enlightening session. You made the topic easy to digest with your clear and comprehensive slides. Thank you so much, Dr. Adhikari.
Thank you, Isha. It's wonderful that you're doing this. Okay, thank you.
Thank you, ma'am.
Yeah.
So before we go on to the next speaker, we'll do a small Alzheimer's trivia poll. Everyone answer quickly because the poll will close after 10 seconds, okay? For each question. Okay, so a lot of you got it correct. Oh no, most of you didn't get it correct. So basically, the neurodegenerative changes start 20 years before memory loss and the other early signs even begin showing. So that's why it's 20 years prior. Now the next question. Okay, we'll close it now. The second answer is right, but for a different type of dementia. I think there was a mistake in the poll. The actual answer is depression, and some of the commonalities are like in mood changes, there's apathy, general discontent, loneliness, mood swings may be present in the early stages. Then lack of concentration, irritability, restlessness, social isolation, loneliness, etc. Okay, so next question. Yeah, we'll be closing the poll shortly. Yeah, so after the death of the patient is right, you find out like the proper confirmation only in post-mortem autopsy. So microscopic examination of the brain tissue sample shows amyloid plaques and fibrillary tangles. Yeah, so we come to the end of our poll. Geriatrics is an often overlooked but increasingly important field. Don't we all want to give back to the elderly who have been instrumental in shaping our lives? With the prevalence of Alzheimer's disease trending upwards, the dire need for better education on the topic is becoming more and more evident. And who better to guide us through how to care for those suffering from this ailment than this esteemed panelist? She is a consultant geriatric psychiatrist who, after completing her post graduation in psychiatry in India, worked in the UK for 8 years and completed the Members of the Royal College of Psychiatrists exam along with specialist training in old age psychiatry. She returned to India and proceeded to steer dementia care services of the Nightingale's Medical Trust, a prominent NGO based in Bangalore, for 8 years. She is currently practicing in Indiranagar and also is associated with the Green Oak Initiative, where she upholds their mission of building resilient communities. The Green Oak Initiative has a wonderful elder care program that my entire family vouches for. as my grandmother greatly benefited from their program, which included exercise, social interaction, arts and crafts, and a lot of fun things. Um, this panelist specializes in managing challenging behaviors in dementia through a holistic approach, which includes medication, supportive psychotherapy, individualized care plans, and caregiver training. She has vast experience in managing patients in residential care, daycare, and the community. She has played an active role in several awareness and advocacy campaigns and has conducted training programs for students, professionals, and family caregivers. So let's welcome this gem of a human being who's known as an avid public speaker, whose patients describe her as calm, empathetic, confident, and amazing listener, and the list goes on and on. Dr. Soumya Hegde.
Thank you, Isha, for that over the top, what should I say, over the top introduction. I think we'll let the audience decide. Yes, I have been working in the field of geriatric psychiatry close to 20 years now. And I've learned so much from the people I have interacted with. Dr. Prabha Adhikari, I have always held her in very high esteem. She's someone who's brought her personal experience and passion to do so much for geriatric care, and we saw that in the presentation. Dr. Prabha, I know if you can hear me, I can't hear you now. But it was a wonderful presentation. It's always lovely to hear the work that you're doing, and you bring that personal touch to your presentation, which is so amazing. Actually rating yourself and your risk for developing dementia. That shows how each of us working in this field needs to be aware that this is something that we could be faced with in the future. As a medical student, I don't think I had even heard the word dementia. It was only much later while doing psychiatry and then further training in the UK when I became familiar with this condition and the devastation that it can cause within families. My own grandmother had dementia too. So, you have all of us here telling you that dementia is very, very close to us. It's not something that has happened to our neighbor or, someone we don't know. It's happened to, Dr. Prabha's father, Isha's grandmother, to my grandmother, and we didn't really know what to do about it. At that time, when my grandmother used to see monkeys hanging on curtain rods, I didn't understand what was going on. And she now looking back, she probably had Lewy body dementia, but we had no idea of knowing that, 35 years back. So, it is something close to all of us, and that's probably why we want to do more for this cause and make sure that the trauma that our own families experienced isn't something that other families have to go through. We want to minimize that to whatever extent that we can. Okay, so I will start with this quote. I'm interested in the future because that is where I plan to spend my next years. And that's exactly what I meant. As a medical student, I didn't know much about dementia, but now I do. And as medical students today listening to this talk, I hope that if that's me next, developing dementia and needing care, you will know what to do for me. So I've put a few slides, which I think Dr. Prabha Adhikari has already covered. So I will just skip through them quickly. As you can see, the elders are the fastest growing population today. And Alzheimer's, as Dr. Adhikari said, age is the greatest risk factor for this disease. And beyond the age of 85, that risk increases to nearly 1 in 2. And as the quiz that you had just before my presentation showed, the signs of changes in the brain start way before we actually see the clinical signs and symptoms, which means that each of us needs to take care and build that cognitive reserve that Dr. Adhikari was talking about. That is what will help us push dementia from 60 to 70, 70 to 80, even if the plaques and tangles have already started depositing in our brains. Okay. In India, there are over 5 million people affected by dementia. And I always feel that this number is just the tip of the iceberg. We still don't have standardized rating scales to diagnose. People are very, very unaware, and that's why it goes unrecognized and undiagnosed. So the 5 million figure is the tip of the iceberg, and we need to do more to create awareness so we get the right figures, and we can kind of move policy development to provide more care and support to families who are trying to take care of their relatives with dementia. So, as Dr. Adhikari said, we don't really have a cure for dementia, but it can certainly be managed. It can be managed better so that the person with dementia continues to have a good quality of life until the end, so that the burden of care isn't as much on the family and they can continue to share the good relationship that they had. One of the worst things about dementia is that it changes the person. And so often I find that families have forgotten what the person used to be. And the last 2 or 3 years, when behaviors are so difficult, they only remember that, getting to a point, where they start wondering, when will all this be over? I can't continue caring for this person like this. So we try very hard that that should not be the case, and families should remember the person with dementia for who they were and try to see this just as an illness. So just touching upon again some of the things that you heard in Dr. Prabha Adhikari's presentation as well. Often this is the stage, the early stage, where you don't know what is happening. So, for example, we've had people telling us, or caregivers telling us later, that he was trying to tie his shoelaces for over an hour and was so frustrated. They didn't understand why. He used to talk about people coming home and having conversations with them. Now, these things don't happen every day, they would happen once in a way. There would be a Sunday when the husband is sitting down for breakfast and the wife asks him, "Why aren't you getting ready to go to work?" She'd forget that it's a Sunday. Sometimes they would argue about everything and get violent, which they would have never done before, a complete change in personality. We would also have people accusing the maid, accusing the daughter-in-law of wearing their clothes. Just like Dr. Adhikari said, sometimes they believe that the son is actually their would-be husband. So these kind of situations happen, and the person, they don't realize that they're not deliberately doing these things. These are happening because of dementia, and this stage is often overlooked. In the middle stage, it becomes worse because there's more issues around wandering. They spend a lot of time in the bathroom because the executive functions start to suffer. So they cannot sequence the steps involved in taking a bath or wearing their clothes. Undressing, dressing becomes an issue, and hygiene becomes a huge problem for families. They refuse to take a bath because they cannot have somebody else help them with this very, very private activity, but they would just get inside the bathroom and come outside and say, "It's all done. I don't need to go back in there." So that's a huge struggle for families. One of the most common behavioral problems that I see is when patients refuse to take a bath or help the families, or allow the families to clean them after they've made a mess. The other problem is when they are so scared of being on their own, they're constantly following the caregiver. And it can be really, really hard because they will follow, they will keep asking the same question over and over and over again. And it's not funny because it isn't like once an hour, it is every 2 to 3 minutes, and you get tired of answering them. There are times when family members tell us that they had to lock the door, slam the door, or even get physically violent towards the patient with dementia, and they feel so guilty doing that. And as the clinician, you've got to hear them through. You've got to hold their hand through this journey because it is hard and it is frustrating, and it is natural for them to get to that point if there is no help and support available. As Dr. Prabha mentioned, towards the advanced stage, the patient becomes completely dependent on the caregiver. They are unable to communicate or move. The big decisions at this point with regards to clinicians is, of course, the decision regarding feeding. What do you do when a person with dementia can no longer swallow? Do you advise tube feeds? Do you ask them to just continue with palliative care and do as much as you can? Think, in India we have a choice. We do have the ability to have Riles tube insertions and PEG tubes when we are faced with a situation wherein a patient with advanced dementia cannot swallow and is a high risk of aspiration. But abroad, in UK and even in the US and maybe some of the other developed countries, the decision to insert a tube, it doesn't lie with the families. The care team makes that decision, and because there is no evidence to suggest that the prognosis of the condition is better with tube feeding, you're actually not allowed to tube feed. The patient at that point moves into palliative care. But in India, it's hard because the family has to care for the patient at home. And at that point, when they're not able to feed, and there's a lot of literature around feeding and care and how we equate care to feeding. If the spouse can feed the person, she feels that she's done her seva towards the person that they're caring for. So feeding plays a huge role. So as a rule, I don't discourage completely because I know it is very hard to do palliative care at home. And if patients are insistent that they want the tube feeding, then we go ahead and allow them to get the Riles tube inserted, and the family continues to care for the person at home. It prolongs the period of suffering for the patient, but somehow the family members feel less guilt when the time comes because they feel that they did as much as they could. So recurrent infections in end stages is another thing that patients struggle with, recurrent respiratory tract infections because of aspiration. And again, there's a whole lot of advice that you can give them around swallowing, the best method to help the person swallow, and the kind of consistency of foods. So these are all things and advices that can be given to patient families to ease the suffering during this stage. This I felt was important, and I wanted to touch upon this, that many doctors are uncomfortable when giving the diagnosis of dementia. So there are again lots of studies done on, do patients of dementia want to know the diagnosis? And the truth is they would want to know. It's what I would want to know if I had dementia. I would want to understand why this is happening to me, that there is a condition which is beyond my control. But family members find it very hard to break that diagnosis, and doctors do too. They don't tell the patient's family that this is dementia. They probably, they give a very woolly kind of a diagnosis. There's no specific terminology used. They may do some of the tests, but they find it so difficult to tell the families that this is actually dementia. But what they are doing by not giving the diagnosis of dementia is depriving the family the opportunity to prepare themselves for what's coming up next. And I think that in this journey of dementia, post the diagnosis, if the diagnosis is made at the early stages, there is a lot of role in terms of, the medication and the supportive therapy that we can provide to the patient and the family members, which will help them. There are lots of decisions that they need to make early on. Even legal decisions, things around driving, around power of attorneys, making a will, these become more difficult as the illness progresses. And if these things can be tackled at an earlier stage because a clear diagnosis has been communicated, it makes life a lot easier in the future. I have had my families come to me regularly for follow-up and keep asking me, what should I expect next? What happens next? What is the next stage? When do I know that the advanced stage has come? And when that stage comes, I find them coming back to me and saying, you told us this would happen. We were prepared. You told us that we need to get this sorted at home. You told us that we need to put in this level of extra support at home. So when that stage came, they were better prepared. And that wouldn't have happened if we hadn't given a clear diagnosis of dementia. The other thing is that every caregiver differs in their ability to care. I cannot expect all my caregivers to care equally. I cannot expect the same level of patience and understanding from all the spouses and children. So it is not my job to be judgmental. It is my job to understand the limitations in a particular support setup and advise on what would be ideal for the patient and see if I can get that sorted for them. So if I find that there is a huge amount of baggage in a relationship, a very traumatic and abusive marriage, then it wouldn't be right on my part to expect the spouse to be more caring and patient and gentle because all her life she has been traumatized by this husband. It wouldn't be right. So that's when we involve the other family members. We try, at least I certainly try and see how can I still provide care for this individual with dementia, but not expect so much from the spouse because it is also her that I have to worry about. So Dr. Adhikari touched upon these, so I will not dwell on that. There's all cholinesterase inhibitors and memantine, which is the combination of medical treatment that we would start if the patient comes to us in the early to moderate stages. Now, moving on to the condition where, generally you will see that the initial diagnosis of dementia in our country is mostly made by the neurologist. And patients come to me mostly when they have behavioral and psychological symptoms, when it becomes very difficult for the families to manage the behaviors, not so much the memory impairment. So these are called the non-cognitive symptoms, and they affect nearly 90% of people with dementia. Dr. Adhikari spent some time discussing each of these with you, and this is where the major burden of care rests because the person is agitated, the repetitive questioning, sometimes comorbid depression, psychosis, aggression, restlessness, and wandering. So, wandering, again, I'm just going to mention that briefly here that a lot of people ask me, they give me a history that the person's routine is every day he goes out to buy milk. The milk shop is just outside the gate, and that's his routine in the morning. And should we stop him from doing that? And at what point would we know that he can no longer do that? Do we precisely know when he moves from one stage to the next where wandering becomes a risk? And the problem with that question is that we don't precisely know when. We won't know when. So the best thing to do is once a diagnosis of dementia is made, look at everything that the person is doing and try to make those activities safe. Not curtail independence because we still want them to do their routine. That's so important for their cognitive, stimulation, but make it safe. So if there is an individual whose daily routine involves going out and buying milk or vegetables outside, that's absolutely fine, but I need to track that individual, and if they don't return within the half an hour that they normally do, then I need to see where they are. So we have some fantastic gadgets available in the market now, and if again this comes with early diagnosis, right? So if we've educated the family, educated the patient wherever possible, and get them to understand these risks, then we can get the patients to understand why we would like them to wear these tracker watches, or why we would like them to carry a phone with them anytime they step out of the house, so that we can track their precise location. And the trauma that families go through when an elderly person with dementia can't be found can be avoided. It is an extremely traumatic experience which thousands of families go through every year in our country, where the person just wanders off. It takes just a small thing as turning right instead of left, and they've lost their bearings. They cannot figure out where to go from there, and they get lost. Sometimes it's 2 days, it's 3 days, but the experience is so traumatic that they remember how they felt and they're so scared and anxious for days on end. So it's best to avoid these situations by making sure that you have these safety measures put in place. So what is the impact of behavioral and psychological symptoms? So we mentioned what these symptoms are. So on the caregiver, extreme burden and caregiver burnout, distress. Lots of caregivers become depressed. They start having lots of physical health issues themselves. They can no longer continue caring for the individual because they are totally burnt out. They may start becoming abusive, as I mentioned, towards the patient. The patient might be ignored because they don't know what to do. They may lock them up in a room. They may tie them up, as the picture that Dr. Prabha showed us at the beginning of her talk. They're reprimanded, restrained, sometimes over-sedated, and when they can no longer carry on, and if the option is available, institutionalized. So the biggest reason for institutionalization is not the cognitive impairment, is not the loss of memory itself, but behavioral and psychological symptoms, which are so hard to take care of at home. So let me just focus on these BPSDs, because I believe that I'm speaking to the clinicians of tomorrow, and I would really like you all to give attention to these symptoms if you all see patients with dementia in your clinical practice. So have a look at this picture. So when we talk about a behavior or a symptom, we mean a behavior that causes harm or distress to one or more of the following: the person themselves, another person with them, or the wider community. So for example, if you look at the two fishes in the fish bowl, there's one complaining that, would you please stop chewing with your mouth open? Now, if you look at that little picture, chewing with your mouth open does not affect the fish itself or the fish in front of him. And the same is true for a lot of symptoms that we see in dementia. And we need to ask these questions before we proceed with any kind of management. We will try and treat only those symptoms for which we have a yes to at least one of these questions, that the behavior causes harm to the patient themselves, to the person who is living with the patient, or to the community. If the patient is only quietly saying things, muttering to self, it's not loud, and it isn't tiring the patient out, and they don't seem to be bothered or distressed by that, I would do nothing. I know the patient's family keeps coming and telling you, do something about this, because he's constantly talking to himself, but I would do nothing, because that particular behavior is not harming the patient and not harming the people at home. It is distressing, I agree, and I would address that distress if the person is shouting or screaming very loudly, which makes it difficult for the other people at home to do what they're trying to do. So let me ask you, and I don't know if you can answer me on the chat. So Durga is 80 years old and lives by herself. She is independent and does not require much assistance. Her husband passed away 2 years ago and she misses him terribly. Since the past month, her son has found that she cooks for 2 people and has a conversation with the other person on the table while having her meal. The son is, of course, very concerned and wants something done. Should we do something here? I am not able to see the chat, so Isha, can you hear me?
Yes, ma'am. We can
Is
hear
there
you.
any way
Yeah,
I
the
can
pardon me?
is there any way I can see whether the audience thinks that we should act in this situation? Should we do something based on the previous slide where I asked the 3 questions that need at least one yes?
Yes, ma'am. They'll send the answers to me. Only the organizers can see the question panel.
Okay, so what do most of the audience feel? Should we address this problem? Should we do something?
1 minute, ma'am. Everyone put on your questions icon. Then we'll be able to see, and even ma'am will be able to see.
Most of the people are saying no, ma'am.
Good, good. So now let's go on to the next situation. Okay, so the same lady, Durga, she's 80. And now, since the past month, her son has found that she is terrified of sleeping alone at night, as she believes that are other people in the room and is asking them to leave her alone. Now, should we do something? Yes, no?
Most of the people are saying yes now.
Okay, good. Because that's exactly what I wanted you to understand, that we don't treat the symptom, we treat the distress associated with the symptom. So that's the most important thing to remember, that a lot of times family members will come to us and tell us things like they don't sleep the whole night, they're up the whole night. But what are they doing the whole night? Nothing. They're just sitting up in bed, maybe, opening their cupboard, taking out their clothes, folding them, putting it back in. Doesn't matter then. As long as they're not shouting and screaming and putting themselves at risk, opening the doors and leaving the house, I would do nothing. If I try to address that problem of them not sleeping at night, I'm going to mess up their entire diurnal cycle, which means that they might start sleeping more in the daytime and not be able to focus on some of the activities that I want to try and do with them. So the only time that we would treat with medication is if the person with dementia is distressed by what is happening to them. Okay, so we have to ask the question whenever we are faced with a symptom, who is it a problem for? Can we identify any cause or trigger? Sometimes the triggers are very obvious. They might have mirrors in the room, and every time they look in the mirror, they have forgotten what they look like, and therefore assume that the person they see in the mirror is somebody else. And this symptom is extremely common in dementia. So the simple, intervention here would be to get rid of the mirrors or the reflective surfaces in the room. Sometimes people misinterpret, patterns on curtains or carpets or even tiles on the floor with a black spot, or those black tiles in between the white tiles. These are all causes of concern and fear to the patient because they have visual spatial difficulties. If we know what's causing or what's triggering, and if we can find a pattern, then it's easier to intervene. So again, intervention is required only and only if there is distress, and also address the fact who will benefit from the intervention. The intervention has to be beneficial to the patient too, not just to the caregiver. Okay, so whereas we do have antipsychotics that can be prescribed, we need to be aware that antipsychotics numb the brain. The way they act in these conditions and eliminate these symptoms is by causing, or is by, making the person not think at all. So in patients where we have had to prescribe antipsychotic medication and I have reviewed them after a month, I have found that their speech is more slurred, they are unable to walk as stable and steadily as they were before. They are also probably unable to do some of the things that they were still doing before the antipsychotics were prescribed. And that's when you really have to make a choice and decide whether we're doing more harm or good. And you have to balance that out. With antipsychotics, the rule always is start low and go extremely slow. So when we use risperidone or drugs like the other atypical antipsychotics in dementia patients, the doses are extremely small. So if you're used to prescribing 1 and 2 milligrams in adult patients, we look at as small as 1 drop of risperidone. 0.25 milligrams of risperidone would give you great results too. So start with the lowest possible dose and build the dose up. Explain to the families that this is the reason why you are reluctant to start with high doses, because it will become harder to take care of the patient if they start losing all their faculties as a result of the prescription. So what are the other things that you could do? Now, these pictures are from an institutional model, and not all of this would be available or possible at home. Dr. Prabha Adhikari's model of, active aging centers permit us to try out a lot of these in patients. And I think we need to change the mindset of the elders that we have, that there is no shame or stigma attached to going to a place which would benefit our cognition. It is not that the family members cannot take care of them at home, but it is that what they need for their illness perhaps would be better provided at a facility where these resources are available. So daycare centers certainly go a long way in trying to reduce the burden of care where the person is taken care of during the daytime and they are kept engaged and cognitively stimulated. And when they come home in the evening, the family has had the chance to rest, to finish off all their jobs that they had to do, so they can devote their time to taking care of the person with dementia. The need for medication also goes down considerably if people are able to do some of these activities at home or at a daycare center if that is available to them. So when we talk about person-centered care, it could be anything. And it could be, these are some of the examples of things that we have used. And I put this list up to show you how trivial these things actually are. But these were the alternatives to prescribing antipsychotic medication in some of my patients. So we have teddy bears, doll therapy, which is a form of the person with dementia probably relates to this inanimate object and starts talking to them, which is fine because they feel better doing that. There's no distress, there's no fear, there's no anxiety. Lollipops for patients who are constantly licking their fingers and mouthing things that they should not be. You just give them a lollipop if they're not diabetic, and that sorts the problem for a reasonably long period of time. Food plays a huge role in managing difficult behaviors. The number of times a chicken kebab or a biryani has resolved agitation is not funny. So it's something that has worked, and it's something that can be done easily. So you need to think about these things. Provide what the person craves for, is happy with, and you would have resolved a lot of the difficult behaviors. A routine plays a huge role too, because people with dementia get frustrated when they don't know what they're doing next. As Dr. Adhikari said, her father wanted to go somewhere every day. That was a part of his routine. Now you need to put that in place by doing it safely. So he started attending the active aging center. In his mind, he was going somewhere, but it was a place that was safe for him and useful for him. The same way, patients with dementia, if we set up a routine for them and if we can display the routine, it makes it much easier for them. So you say that, you have a clock on top and a small calendar, or a board, a whiteboard just below that, which indicates to them what is going to happen next. It really helps in calming their anxiety down, because then they know what to prepare for and what to look forward to. In terms of the communication strategies for a person with dementia, you need to assume that the person with dementia can understand much more than they can express. So even though the scores on the cognitive tests drop, you need to know that every time you talk about the person with dementia in front of them, they do understand that you're talking about them. So it's the first thing I tell families is that, we will not talk about the patient in front of them. If you need to talk about them, then we will do it before the patient is brought into the clinic room, or afterwards. You can call me separately on the telephone and talk to me about your concerns, but not in the presence of the person. It worries them, it makes them more scared, and they become more anxious about what is happening to them. So do not talk about the patient in front of them. Always begin the conversation by identifying yourself and calling them by their name. That sets the context of what is about to happen. A lot of dementia care facilities, we have the staff put a name label on their clothes so that it's easier for the person to address them by name. Use short and specific familiar words. Do not use long sentences. They get lost. They're not able to follow. Break the steps down. So because I said earlier, they have trouble with sequencing activities. So if you can break down the task for them, it becomes much easier for them. Ask one question at a time if you have to ask questions. It would be best and ideal if we don't ask them questions and keep testing their memory. Often asked by family members, is it okay to keep asking them and reminding them who they are and who we are? No, it's not ideal. It's not fair, because each time we do that, it's another nail in the coffin that I don't remember. And this is my family reminding me of that. Use facial expressions and hand gestures to express your concern. The non-verbal communication goes a long way in conveying what you want to. They may not understand the words that you speak, but they do understand how you make them feel. Immediate reassurance and rewards are also very important. Anything small that they do, reassure them, make them feel great. What often happens in dementia is we point out their mistakes, we point out where they forgot, we forget to appreciate what they did right. The more we are able to do that, the less anxious they become about what's happening to them. Show respect for their feelings, even if the facts are incorrect. So they may say that they are 50 years old and then they're still at work. That's fine, as long as they are happy talking about that. They're happy thinking that they're in their 50s and still going to work. It doesn't do any harm. So we continue. I think there was a question from the audience: should we keep reminding them about a painful event? I've had patients who have believed that their spouse is still alive and will come home at 5 o'clock every evening. And I have let them believe that, because telling them that their spouse is no more is going to cause them a lot of grief. At some level, they probably do, but they don't want to believe it. And therefore, I go along with that story. If they think I'm their daughter, that's fine. If that makes them happy, that's fine. So we do not constantly orient them. We validate their feelings, we validate how it makes them feel, and we go along with their story. So, in summary, early diagnosis and caregiver training is extremely important, and something that, the more awareness we create about dementia, the more hopeful we are that people will come forward sooner and understand what's happening and get the kind of help and support that they need. Person-centered care planning. There is no general rule of care plans. It's not like an antibiotic that I can give based on a culture report, which will be the same for every patient. It isn't. It is very, very individual. It is based on the person's previous life, their occupation, their personal interests, their personality, the personality of the person caring for them, the resources that are available. So person-centered care planning is extremely important. Changes in the physical environment to suit the needs of the patient with dementia will also help. So there's lots of things under this, which is called nidotherapy, is changes in the physical environment as the person progresses in their cognitive impairment. Provision of purposeful activities. One of the main things that I find that keeps people alive is a sense of purpose. What if I had to get up tomorrow and I had nothing to do? Nobody really needed me to do anything for them, and I didn't know what I had to do today. How would I feel? I would feel completely, barren inside, a complete void inside of me, and a deep depression. So, a sense of purpose, even if that purpose is watering a plant or taking care of an animal or feeding a cat, is a purposeful activity. Buying milk, dropping the grandchild to the bus stop is a purpose. Make them feel treasured for that little thing that they do. Make them realize how much they are required in your lives because they still contribute. And that keeps that person going. Involve extended family and friends. Do not be ashamed of the diagnosis. I always tell family members there is nothing to be ashamed of in a diagnosis of dementia. You did not cause this diagnosis, you did not cause this illness, so you don't need to be ashamed. There was nothing that you didn't do or you did to make this happen to your spouse. So it is important that family members understand. Family members also sometimes give unsolicited advice because they don't realize what the family is going through. Wherever it is, in my capacity, I do try and reinforce to the family that, you're dealing with this. The other people giving you advice are not really in your shoes. So you support families in making the decisions that are right for them and for the patient. Professionals need to be more patient and tolerant. It takes a long time to assess a person with dementia. It's not something that can be done in a busy practice. We wouldn't be doing justice in terms of the care to be provided. So if you're working in a hospital setting, try and establish a geriatric clinic or a dementia or memory clinic where you can give them the time that is required. Enroll social workers, psychologists, and try and do a follow-up of the patient after the diagnosis. That is perhaps the time when they need you the most, because once you give them the diagnosis and let them go home, they would be shattered. So you need to hold them through the process of accepting the diagnosis. Practice the good practice guidelines, like I said to you earlier, in terms of prescribing antipsychotics, start slow and go really slow. And the community and government support. Often people are not aware of the resources that are available in the community. As Dr. Prabha Adhikari has done in Bangalore, there are a lot of support systems available to people with dementia and their families. And if you are somebody who is working in this area, you would be aware of those and you need to share it with the families that you see. The COVID, the whole situation that we have had for the last 6 to 8 months, has posed very new challenges to us. And it's been very hard on the caregivers because, it's resulted in lots of daycare facilities closing down. And patients who have been used to attending daycare facilities are now at home. And there's also the additional burden that the caregiver now has to, handle all the other household chores for which they had help previously. A lot of difficult behaviors have escalated during this process. Also, the person with dementia does not understand what COVID is all about. They may refuse to wear a mask or wash their hands, and they are extremely high risk because of their age, and some of them are immunocompromised too. So it is hard to maintain the hygiene practices and changes that have to be brought about in their day-to-day lives. More activity at home wherever possible. And I think the mainstay of management during COVID times has been supporting the caregiver. And perhaps my medication dispensing has increased marginally because you do not have a lot of resources that were available to us before COVID. So, and we keep reassuring the person that, once this whole situation tides away and hopefully it is brought to all our daycare centers opening up, things will be better again. So supporting the caregiver, even if it means just a debriefing, would certainly help and go a long way. So caregiving and the carer, I think I've mentioned it earlier, but caregiving is, the dementia caregiving is it's the provision of care over and beyond what we would have expected to do for our spouse or our family or our parent as they get older. I've had people telling me that I was prepared to give them a bath, feed them, but I was not prepared for this. I didn't realize that there would come a time when they would not recognize me while I'm providing care, and it is extremely painful. It also involves a significant expenditure of time, energy, and finances. So these things have to be taken into account at the beginning itself so you can prepare the family accordingly and do what is necessary in terms of collecting resources in the community. It is not always pleasant and comfortable. It is extremely psychologically distressing and physically exhausting. And the problem with care is it escalates over time. So as with every stage, the kind of care that is required is different. The stress on the caregiver also continually changes and is not static. The sad part also is that in dementia care, or in India, the dementia care is almost entirely home-based. It's a very small proportion of people who have access to daycare facilities, community support teams, or institutionalized care. So most of the time, the brunt of caregiving is borne by the family members, and there is no escape. It is a 24/7 job with no other recourse. So I'm ending with this quote. You start by doing what is necessary, absolutely necessary, and you tell the caregiver to do what is possible by them to do. And suddenly, as you realize, and as time passes, you realize that the caregiver is actually doing the impossible. Things that they had never, ever thought that they would be doing, they end up doing. And there's where you need to support them and provide them, with all the advice and resources that you have available so that the burden of care is minimized and they can continue to care for this person and remember them as they always were. Thank you very much for a very patient listening. I'm happy to take any questions if there are.
Thank you, Dr. Soumya, for this very informative and interactive session. I'm sure the students have learned a lot about taking care of their grandparents as well as this session will help them become better clinicians in the future. There are a few questions that people have asked, so I'll be asking them. If anyone wants to ask a question, they can put it in the question panel or unmute themselves too. So, ma'am, have there been instances where reminding them or giving them a prefix schedule made the person feel dependent, leading to the patient going into depression, considering that they already feel dependent due to their age? This was asked by Urvashi Kumar.
Okay, so what we find is that having a prefix schedule, depending on the person's interests and daily routine in the past, is what we want to do. We're just giving them a prompt, and as I think Dr. Prabha Adhikari mentioned, the use of memory aids as we are getting older. You need to normalize the use of memory aids. We do this all the time, right? Even I have a shopping list. I can't recall all the items that I need to buy. So I put things down on my phone or I write it down on a piece of paper. We use spectacles as we get older to help us read. We use hearing aids if we have trouble hearing. We even use a walking stick if we are unsteady and have a risk of falls. So it's not about making it a big deal, but it's about trying to explain to the person, this is how you can keep yourself active and doing the things that you want to do. So a prefix schedule should not be something that you want the person to do, but it should be what they want to do, but you're just providing them a prompt so that they will remember what happens next. So if there is a calendar, I always ask them to buy a monthly calendar and put down things like if they have to visit a temple, or they have to if they have a doctor's visit coming up later in the month, or if they have a relative visiting them, or if they are, entertaining somebody or going away on a holiday, or they need to make a phone call to wish their grandchild for their birthday. So we have these things displayed very clearly. And as each day is over, the next day we ask them to cancel the previous day so they know clearly where they are in that month and what is the schedule for the day and for the month. I haven't seen people getting more depressed as a result of this. I think it liberates them and makes them feel more in control, because people aren't telling them what to do. They're figuring it out for themselves with a memory aid.
Thank you, ma'am. Ma'am, we have another question by Mr. Saurabh. How do patients at early stage or middle stage dementia take into account the news of diagnosis by the doctor? Is it good to break in the diagnosis to the patient?
So, as I said, Saurabh, there are studies to show that patients actually want to know. So I didn't put up that study, but there was a study done, I think I think it was in the 2000s sometime, where they asked patients, where they asked a couples. They asked the person and they said, would you want to know the diagnosis if you had dementia? And most people said yes. Then they asked them, would you like to tell your spouse that they have dementia? And most people said no. So it is more about how we perceive the other person will handle the diagnosis. Whereas if you ask yourself, you would want to know. But we worry that this might upset the other person. Of course, this is individual because, I have also seen some patients who become extremely anxious about their health. And those are the kind of people perhaps that we would not tell them the diagnosis. But for the most, they want to know the diagnosis. And you again, as I said, you try and you don't you know what's the word that I'm looking for, you don't really reduce the intensity or the severity of the condition by giving them the diagnosis as, say, starkly this is dementia, but you have given them some time before you give them the diagnosis. So you may not do it at the first time that you've seen the patient. You might tell them something like, yes, I am concerned about your memory today, so these are the things that we are going to do, but I'm not really sure what it is right now, but we're going to try and engage you in these activities for now. We're going to get a neuropsychological testing done. We're going to get an MRI scan done. And we are going to, even start you on some of these medications. If I suspect there's a bit of depression or anxiety, I would start them on medication for that. And I say, let's come back with all of this in the month, and then we will talk about what's really happening. You won't believe that this 1 month that you give them to actually think about clearly that, okay, the doctor does think there is something wrong with me, but I need to understand really what is happening. And it breaks the kind of the intensity of the onslaught is broken considerably when you give them the diagnosis after a month, because by then they have also had time to process what is happening, and that there is really something, because all along they would have known something is happening to me, but I don't really understand what it is. And knowing that they are not responsible for what they're feeling, but there is an illness, actually makes them feel a little calmer. And then you go about, so that again, not every dementia follows the same path. Different people live for different years with the diagnosis, and early diagnosis and treatment, as Dr. Prabha Adhikari said, we have been able to stretch the early stages before persons become dependent on their caregivers for as much as 10 years, which is a good length of time. So I don't think there's any you need to support the patient, you need to talk to them about it, you need to ask them at every follow up how they are feeling, which is why, as I mentioned to you at the previous question, that the most important phase is after you've given the diagnosis, what are you doing next, how are you supporting them, are you giving them or making a call and talking to them after that, or talking to the family members after that, or if you have a community support team, are you able to send somebody out to visit them at home and see how they're getting on. So these are things that we need to look at and make sure that it's done.
Thank you for this beautiful insight, ma'am. Dr. Anagha Rao is asking, can patients with Alzheimer's form new memories, and is it true that they are on a loop in a memory from their past?
They can form new memories, but I think I'm not really sure what you're looking at. So if you're trying to retrain their mind, so for example, there's a person, they've moved into a new home, and initially they may find it hard to realize, where is the toilet, where is my bedroom. So we give them prompts. We ask the family members to label the doors, because otherwise all the doors in a house look the same. So you put a little board on it which says toilet or bedroom, maybe arrows from the living room or from the bedroom towards the toilet, so towards, to wherever they want to get to. And we have seen that this kind of retraining helps the patient and they eventually learn. The same with repetitive questioning. One of the strategies we use is, if a person, there was this, I'll give you an example. There was a woman who was living with her son and a caregiver, and the son would go to work every day and be back at a certain time, and she would be so anxious until he returns, and her only question to the caregiver would be, when is he coming back, when is he coming back, when is he coming back. For this lady, what we did was we used a whiteboard and we clearly put on the whiteboard, he will be back at 5 p.m., and we had a digital clock on top of the whiteboard so she could see the time. That really calmed her down. And initially, it took a few prompts where the caregiver would take her to the board each time she asked the question and say, see, look, read. And eventually, she stopped asking the caregiver the question and she started going back to the whiteboard herself because she knew what she had to do. So, that type of retraining or putting new memories in is possible. Sometimes with a memory, they may not remember the facts, but they will remember how they felt. So, for example, if you play a game of snakes and ladders with them and they really had a good time, so the next time they see you, they may not remember that they played snakes and ladders with you, but they will remember that you made them feel happy. So it's not always, the memory is not as crystal clear as it is for someone without dementia, but there are certain aspects of the memory which can be stored and which are stored. The same way, if you are somebody who has made them feel terrible, perhaps you've come home and constantly asked them questions that have made them feel very, very embarrassed because they didn't have the answers. So, again, the next time they see you, they may not remember what it was about you that they didn't like, but they would certainly remember that you made them feel uncomfortable and perhaps would not want to join in any conversations this time. So I hope I've answered your question, Anaga. They're not in a loop as such, but as the dementia progresses, they forget more and more of the recent years, and their memories of the past, their midlife and early childhood, become more clear.
Thank you, ma'am. Uh, one more question we have. Uh, Priya is asking if alcohol has any impact on the progression of the disease, as in if given as a form of care. as mentioned, or is it a real, or is it a really not regular and small amount?
So again, it was about person-centered care, right? So if there is somebody who enjoys his one small or two smalls every evening, then I would not deprive them of that, because it's the joy that they have and they look forward to that in the evening. And not or denying them that leaves them with no purpose, or in the sense that they feel very void and vacant at that time. And I've seen a lot of people become quite depressed and agitated around that time, that they would have thought they're going to sit down with their one small. So large quantities, of course, are not good. Also, allowing the person themselves to pour out a drink is not ideal, because they may not remember how much and when to stop. But if this is supervised and this is in keeping with the habit that they have had all their lives, then I wouldn't stop it. Is that clear?
Yes, ma'am. Ma'am, are there any government programs available for helping the patients suffering from dementia to reduce the burden and cost on the family?
That's the shame, yeah. At present, there isn't a lot happening by the government. We don't have any government aided daycare facilities. They probably provide part of the funding. I think Dr. Prabha will also be able to ascertain that. But most of the work is done by the private sector and through public funding, as in, volunteers and donors, and patients paying for their own daycare services. This is what is happening in Bangalore. At least we have part government, or part the BBMP and part the private sector or NGOs pitching in to provide. Maybe the premises are provided rent free, but the staff salaries have to be taken care of through the people attending. So it is hard, because dementia is not yet a priority for the government in Karnataka, but it is different in different states. I think the Kerala government has taken this on very positively. There's a lot of daycare facilities which are funded by the government in Kerala. So it varies from state to state. And I think we all need to do our bit in terms of creating awareness, getting the numbers, actual numbers on, so that we can expect from the government to provide more care, because the numbers are high.
Yes, ma'am. Ma'am, Priya has another question. What is done in cases where patients fail to turn up? Either they refuse to come or family refuses to get them.
So, I mean, I have managed a lot of patients without ever seeing them, because it is very hard to see a patient with dementia, for them to come to clinic, expect them to sit for 1.5 to 2 hours for the assessment. It is very hard. So I think I have managed to provide care without seeing the patient. We may not be able to do the cognitive testing and the neuropsychological evaluations, but if the patient's family was able to get me a video of the difficult behaviors, I've worked with that. And through the patient's family, we have managed to get the entire history and the progression, and enable a diagnosis, because the patient might cooperate for a blood test and a basic scan if that was possible, but they would not want to come in to see a psychiatrist or anything to do with their memory issues. So we worked around that. So many patients where I've told them that I'm not a psychiatrist, I'm a physician, and or a friend of their grandchild or their daughter, and tried to just have a conversation with them. This is possible if home visits are possible. It's easier to do an assessment then, but it is not absolutely necessary to bring the patient to clinic to help the family. So I think this is something that we need to send a very strong message across. And maybe I'm taking a risk, but that's the only way to help the family and the patient. But I have certainly managed a lot of patients without ever seeing them, and just seeing their videos and talking to the family members.
Wow, ma'am, that is very commendable. Also, ma'am, we have a lot of questions coming in from our attendees. Another one is, since ma'am, you've been in the UK, what are some of the significant differences in care and attitude towards dementia and meeting a psychiatrist for the same
Okay, so
in
in
UK
in
as
the
in India?
yeah, see, in UK the system is so much more structured and systematic. So you would have, generally one old age psychiatrist for every 10,000 population. And this is, across the country. So you have lots of old age psychiatrists. The patients are first seen by their GP. The GP identifies that there is something wrong. They either refer the patient to a neurologist if they're not sure, or straight to the psychiatrist. Once the psychiatrist sees the patient, evaluates the patient is then referred to the community mental health team, which comprises of an occupation therapist, a social worker, a psychiatry nurse, and a physiotherapist. And the case is discussed with the team to see how many members of this team need to start working with the patient. If the patient is high risk of falls, is living on their own, and or has a spouse who has some other medical illnesses, all members of this team are referred to that patient. And there are also organizations like NGOs, like the Alzheimer's Association, who will then send around a volunteer. And then the psychiatrist's role becomes quite small, because this is the kind of care that the patient and the family needs. So the community nurse then steps in and starts doing regular visits. And once in 6 months, they come back to see the psychiatrist if they have been prescribed cholinesterase inhibitors, or if there are behavior problems, then if you've prescribed antipsychotics, then that monitoring happens through the psychiatrist. And then the community mental health nurse continues to take care at home. If and when the patient develops severe behavior problems, the patient is admitted to a psychiatry ward, which is an old age ward, and an old age ward specific for challenging behaviors. Okay. So this is the acute care facility where you would have patients who were admitted to assess these challenging behaviors. It could be hallucinations, it could be severe aggression, agitation, restlessness, it could be wandering because they cannot be managed safely at home. It could be any of these, and they are kept on the assessment ward until you're able to see if you can find a combination of medication or non-pharmacological interventions that try and reduce the problem. If at the end of 4 to 6 weeks you find that you cannot resolve the problem and the person cannot go back home and manage safely and would not be able to be managed to the level of care that they have at home, or they live alone and therefore continue to be a high risk of falls or wandering, the patient is then referred to the social care support system, where they would be found, they would look for a residential care facility depending upon the challenges. So again, within the residential care facilities, you would have people who are fairly independent and people who have severe difficult behaviors, because the ratio of staff to patient would vary. So again, as I said, it's very, very structured in the UK, whereas in India, you don't have that level of structure. You don't even have that level of support. Very few patients I can have, the opportunity to refer them on to an occupation therapist and see how we could modify things in their home and make it safer for them and convenient for them to continue being independent in terms of taking a bath or making their own cup of tea. There's so many little things that they can no longer do. So I think that's the biggest difference that I found, that here I felt like I had to do, the roles of everybody, that you also have to do a bit of physiotherapy assessment and provide, a set of exercises that they should continue to do at home. You'd also have to look at their home setting quite clearly, ask them about these things and see what suggestions you can make in terms of, making them independent in the bathroom or in the kitchen. You also have to make these regular calls back to see if they're okay, and give and be open to receiving WhatsApp messages and emails from them anytime that they want to, or give SOS advice, which again you wouldn't be doing in the UK at all. But every day I'm probably responding to at least 10 or 15 patients just on WhatsApp messages, because they just want to check with you if what they're doing is right or wrong. So you end up doing a lot of this because that's the only way you can support them. So it is very different, and I hope that we get to a point where we have more support for people who want to, take care of patients with dementia, and that can only happen if more and more people get interested in this line of work. So I'm glad we still have a big attendance, and I hope most of you would consider doing this in the future.
Yes, ma'am, I'm sure the attendees are like inspired by your work and Dr. Adhikari ma'am's too. Ma'am, another question by Swapna is, ma'am, how do you recommend guiding or advising the caregivers with respect to burnout? this being a sensitive topic?
Okay, so I think the first thing is recognizing that there is burnout. So do assess the caregiver every time you follow up with the patient too. Do try and see if you can spend some time with the caregiver by themselves without the patient or their son or daughter who has brought the couple for a follow-up appointment. Because sometimes they don't want to tell these things in front of their children. They don't want to, you know, show the child that they can't care for their father or mother or what the case might be. So try and get some time with a caregiver by yourself and understand what are the difficulties they are facing. How is their sleep? Is their, their physical health okay? Are they experiencing more pain than usual? Are they able to cope with the challenges of caregiving, and where are they really struggling, whether it's financially, emotionally, guilt? So do that assessment. Once you've done that assessment, you need to connect with the caregiver and say, look, unless you take care of yourself, you cannot continue to take care of this person with dementia. Now, it is somewhere we assume that the person who's ill will go first. And that's probably a very wrong, assumption that we make, that because they're ill, they go first. And we need to remember that if anything happens to us, that person will be left without an anchor. Nobody else knows how to care for them. So that's a conversation I have with a lot of my caregivers, and that's one of the reasons I tell them that it is so important that they accept support and they ask for support. So a lot of times, if it's only the husband and wife, and particularly now with a lot of consultations happening online, I insist that the children join the consultation so that I can kind of tell them very clearly that this is what is happening to mom, and I think this is what you all need to do, be it financially or emotionally or stepping in practically to be there with the father and give mom a break. So I think this goes a long way, because the spouse particularly feels very guilty asking for help, but it's much easier as a clinician if you kind of dictate that and say this is a part of the treatment, that they need to have time for themselves, which means that if you want to advise daycare or respite care or getting somebody else from the family in for a couple of hours, a couple of times in the week, then it needs to be done. Have I answered the question?
Yes, ma'am. Dr. Jewel Jones has asked, can you
Isha, I can't hear you.
Ma'am, 1 minute. I
Isha, I
think
couldn't hear
Ria
you.
may have some connection issue. If everyone else's questions, there are too many right now. So if you all could send them to us, and we'll send them to ma'am and answer your doubts later. That would be great. Thank you so
Yeah,
much,
that'd be sure.
ma'am,
No,
for
it was a
your
pleasure interacting with medical students. Like I said, I rely on you to take care of me tomorrow. So,
definitely, ma'am. And we really learned so much. It was a really lovely session, and you can see that from the number of attendees.
yeah, I know.
Thank you
I'm
so much,
really
ma'am.
glad. Thank you.
I'll give it over to Gayatri now to deliver the vote of thanks.
Yeah. So on behalf of the entire team at IAGSC, I would like to extend a big thank you to Dr. Prabha Adhikari and Dr. Soumya Hegde for contributing their sincere effort and time. And I must mention how touching it was to listen to Dr. Prabha share her personal experience. Definitely, it has changed many of our perspectives and notions about this disease. I would also like to take this opportunity to acknowledge Dr. Soumya Hegde for her wonderful teaching and insight. It was a pleasure listening to you, ma'am. And indeed, it is a great honor to have both of you with us, and we look forward to seeing you in our future events. Lastly, I would also like to thank the participants for patiently listening and actively participating. Thank you.
Thank you.